I just want to say that thank you all for having me. I am a historian, so we're shifting gears here. More than 20 years of experience. My expertise is Europe. I have myself looked at sort of slippery slope, if you will, slow-moving genocides in the Napoleonic era. And so I want to talk a little bit about this today, just a little bit as a warning or so. So I'll just kind of walk through it here. We're going to go to slide number 2. And the first thing I want to do is say that this is not by any means an accusation or charge, but the point is here prevention. And given the realities of what we're facing, this is kind of a clear warning. It's a warning driven not only by the reality of so-called disparate impacts and disparities in health that is now clearly turned into disparate death on a rather mass scale, but also by some of what I heard last week around biomedical and genetic research. For example, the idea that deceased are not human subjects and therefore consent is not required. Or the notion and the temptation is of course high because it is exceedingly difficult to get a hold of specimens apparently. So of course then there's a high temptation to just bypass consent. And then there are also calls which you hear in the media for massive health surveillance. And in addition to the rise of this kind of HLA genotype mapping coupled with excitement, honestly, about conducting comparative studies between African Americans and Africans and so on as the virus spreads in Africa, and wondering if there are any studies looking at the causes of vulnerability in the African American community as it relates to genetics. So these are the kinds of questions that are concerning. Now, that being said, we're all concerned, obviously, about this virus and want the research to be done so we can get along to getting through this or so. Now, but there's an ethical danger here that I want to offer from a humble historian. And that is that a great deal of historical research has been done on the rise of eugenic pseudoscience and other physical pseudosciences and the role they played in the propagation and sustaining of racial ideology, essentialized human difference, and scientific racism, and how that all rolled up and played out in the rise of modern genocides. One example is, of course, Nazi genocide, but there are others. Genocide is now a robust field of historical research, and I want to call your attention specifically to work around medical issues and around sort of scientific issues. And that's the work of Paul Weinlings. He's got a trilogy on medical atrocities during the Nazi years. And as you can see here, the second of that is epidemics and genocide in Eastern Europe. So these are the kinds of things that have been examined or so. You might recall also that the first trial in the Nuremberg trials was in fact the doctor's trial. One of the things that had gone on in these years was, typhus in the late 19th century was essentially turned into a Jewish disease. Indeed, justification for the Warsaw Ghetto was the idea of public health, that the general public needed to be protected against typhus. But in fact, what happened that in the context of that ghettoization, in all of the deprivations that occurred in that context, it actually caused the outbreak of typhus and led to many, many, many deaths even before people arrived at concentration camps. Now, in the doctor's trials, 23 were charged, 16 convicted, and 7 of these received the death penalty. The American, I just want to go back here, the American Journal of Public Health in January 2018 actually offered a series of articles on reflections on the 70th anniversary of the Nuremberg doctor's trial. And here, Dr. Michael Groden, I point him out because he is a doctor, of course, pointed out that atrocities justified and performed by health practitioners serving the Nazi eugenics and euthanasia programs exemplify how small steps along a slippery slope can lead to crimes against humanity. And this is kind of what I'm warning about. So research conducted in secrecy, and if you bypass consent, you're in trouble. We have in this country, we're not exempt by any stretch, a history of the Tuskegee experiment, which went on from 1932 to 1972, sterilization of African-American women who went into the hospital to have children and came out and couldn't have any more because they had been sterilized, so that I want you to realize that especially given the realities that you have a disparate death in the African-American and Latino communities, that you're dealing with populations that have had a history of dealing with lack of access to healthcare or outright denial of healthcare. I, in my own family history, have the story of a great uncle who appeared to be white, had a heart attack on the streets of Alabama. They called the white ambulance, and when the white ambulance found out that he was Black, they didn't take him, and he died on the street. So these are the kind of the stories in healthcare, involving healthcare, that people of color often have. And so that the level of trust that may be there between doctors and some other communities is not necessarily there in these communities. And in this context of COVID-19, I can tell you what I'm hearing are the rise of these sort of heightened fears. So for example, the idea is that, yes, well, there's a decrease in the number of hospitalizations because social distancing is working. But there's another dynamic which is at play, which is that people of color have gotten the message, well, if you go to the hospital, there's a high probability of that you will, obviously not survive the circumstances under which people die alone. So they're simply choosing not to go to the hospital, right? So there are social factors that are at play and not simply the medical factors. I also want to point out then that the context, understanding the context of consent, that the idea of consent in medical research, in fact, grew directly out of genocide and is part and parcel of genocide prevention. So this is not something that you want to bypass. And even in the context of New York law, you can see here the New York Civil Rights Law basically makes it very clear. Biological samples shall mean material, part of the human body, if any part of the human body. You can read this then for yourself and see that there are measures which govern consent, and it's just not something you can bypass. What constitutes genocide? I think people tend to think of genocide as a spectacular event of concentration camps or so and so on. But in fact, it was much broader. And even in the original definition that Raphael Lemkin offered in his book, Axis Rule in Occupied Europe, it was much broader, as you can see here. So it concerned, the disparate integration of political and social institutions, of culture, language, feelings, and so on, and also involved the destruction of personal security, liberty, and again, health and dignity. And so, there are health and dignity issues surrounding how we deal with COVID-19 that I think are important to keep in mind. And we again, don't want to get on a slippery slope where we wind up with issues down the line or so. And again, the notion of genocide as articulated by Raphael Lemkin then, of course, became a part of the 1948 United Nations Convention on the Prevention and Punishment of the Crime of Genocide. And I just want to call your attention to C there, which is deliberately inflicting on a group conditions of life calculated to bring about its physical destruction in whole or in part. That's not a spectacular event. That allows for something that's kind of slow moving, right? For long-term deprivations or disparities or so that then erupt, as we see now happening in the context of disproportionate death of African Americans and Latinos and people of color or so. So, these are the kinds of things I think we need to keep in mind. And then you can see here that the article also calls for complicity in genocide. So it isn't simply that you willfully commit this, but if you are complicit in it, complicit in some way. So again, understanding genocide beyond spectacular mass murder. Helen Fine in 1997 talked about genocide of attrition, and you can see what she wrote here as it relates to the Warsaw Ghetto. The underlying causes of death were in fact German policies, right, which ultimately led to deprivation of the inhabitants of the ghetto, which left them in challenged health positions and so on. It essentially denied them health security, food security, and so on. And even in the wake of this, scholars continue to argue for a long time after this that starvation and disease following ghettoization were unintended consequences, right? And again, that sounds a lot.
Margaret, this is your 1 minute mark.
Yes, disparate impact. So I'm just giving you a sense that that genocide has been much broader. And I'm going to sort of go forward here. I have 2 more slides here left, but go forward here, just give you a sense of this, is that what if genocide were to emerge in the United States? Given our history, the fact is it would probably emerge as some sort of disparate impact. Given the absolute fact of the astronomical disproportionate death of African Americans and Latinos, dismissed as caused by underlying conditions for which they are responsible due to deviant eating habits or behaviors or so on. Given the pathological socio-political realities in which we live, marked by administrative peculiarities, to say the least, coupled with the deliberate destruction of affordable health care and provisions to preserve health security and rights, we may be in danger of a slippery slope into accidental genocide. Demographic transformation could result from this, having an impact on political outcomes where there are fewer voters, and in reality where there have been calls to cancel elections or delay elections outright. What does this all mean with an anticipated uptick again in the fall in the coronavirus in COVID-19? What does this mean in an environment where, as Jeff Shaman pointed out last week, there's substantial evidence of reinfection, and where frankly there simply isn't enough to go around, whether you're talking about medicine or ventilators. I mean, who makes the decision about who gets ventilated and who doesn't? And if you're looking at populations where they've been labeled as having underlying conditions with no explanation as to why those underlying conditions exist, that does make it easier to simply say, yes, we're going to offer this one comfort care and not the other one. So, I applaud doctors and I applaud all the research that is happening, but I think it's worth remembering at this time that, we've had other environments where pandemics or the outbreak of an epidemic has been leveraged actually to commit sort of slow-moving genocides. And so I think that that's something that is worth keeping in mind, especially as you're dealing with populations of color who, for legitimate reasons of their historical experience, don't have the same level of trust in science or in the medical profession as some other populations. That's it.
Thank you, Margaret. Very compelling presentation. Brings us also some very interesting remarks about the potential impact of these on even the elections, because as we know, the last few elections have been determined by a handful of votes. And so
yes,
a disparate death rate in different social classes could actually make a difference in the outcome. I have a question before we open it up to the general public. I think Brent and Wendy are lined up, so I'm going to allow them to talk.
Okay.
But what I want to ask you is, so right now, I think the disparity is determined even after patients have checked into hospitals. So the idea that, so maybe an even greater disparity once we bring in the data about people that died of COVID-19, but not in hospital settings. But what the current disparity seems to point to is either to a sort of a set of underlying conditions that may be more frequent in certain population, or to some differential genetics. For instance, we've talked about the HLA group as being a determinant of potential response to the infection. So do you have any sort of concept of how this could be separated into different type of causes or etiologies?
I think that this is something that, again, when I called last week for greater collaboration between those of us who work in the humanities and those of you who are working in the physical sciences and the medical profession, this is what I'm talking about. I mean, I think this is something that needs to be under discussion. I can't, from my standpoint, necessarily say, okay, what's happening in the, in the ICU or so. That would be an overreach in some respects, because clearly I'm not a medical doctor. But at the same time, these disparities have to be explained, and the background, the causes of these disparities, I think, are something that have to be dealt with in terms of the long-term history of unfortunate realities that there have been discrimination. That there's been discrimination and what has led to this. And again, when you start to think about the changing concept of genocide and the idea of genocide by attrition, that's a very different concept than what we had thought about, in 1945 or so. And so the idea of attrition means that you can have longer term discrimination taking place, and then suddenly something happens and it erupts, right? And and what you see happening oftentimes in genocides is it's not the case that the the genocidaires, if you will, had planned it out, but they take advantage of something that has happened. And, you know, I'm sorry, but you have to, and I'm not being political here at all. I'm not, you know, one way or the other in terms of Democrat or Republican, you know, or as it relates to this presidency or so on, and these kinds of things. But what I'm saying is that the reality is that there's a sort of ticking up of events that have happened that have now lead us to a point where we have massive death amongst African Americans and amongst Latinos, and there are consequences of that are not medical consequences. So there are collateral damages beyond COVID itself, which are almost as dangerous as COVID. Am I making any sense?
Yeah, totally. Thank you, Margaret.
Yes.
So Wendy, do you want to ask your question?
Yeah, thanks so much for bringing the awareness of many of the issues. Just to clarify some of your points, I represent the COVID Biobank, and when we've been consenting participants, just to update the community, greater than 95% of the participants we've contacted, and that's regardless of racial, ethnic status, have been agreeing to participate. So it's been really an overwhelming support in terms of everyone across the community wanting to contribute. And I think that's exactly what we're trying to do. We're all in it together. With the questionnaire, we are trying to get a lot of the information that goes across social determinants of health, differences that are not simply by color of the skin, but many of the differences that we have in New York. And we really want to have everyone represented and counted to make sure that this doesn't happen again as we're doing this. So that's in terms of making sure that everyone has the opportunity to participate, and they really are. The issue in terms of those who are deceased, as you can imagine, they unfortunately don't have that opportunity to consent. And I'm glad to talk with you offline, but the comments that I had made previously are simply about what's called the common law in terms of research. And I can clarify some of that with you, but to emphasize that those who are living and able to participate are very happy to do so.
Indeed. Can you hear me?
Yes, I can.
Yep.
Oh, okay, excellent. And I understand what you're saying, and I recognize that, you know, for those who are living, you're getting consent. And of course, we all, I mean, this disease, this virus is not, you know, sort of picking out people on the basis of color, obviously. And so I'm not talking about color differences by any stretch of the imagination or so. I'm talking about the longer term historical issues surrounding certain populations. And in this case, you know, I think in the United States, we can certainly talk about African Americans and we talk about Latinos, but there's some question of what may be happening with migrants in Europe, for example. All right, so there are a whole host of questions around this. And yes, I hear what you're saying with regards to living, but even with regards to the deceased, right? You know, there's still an issue there, I think, regarding consent, which is not necessarily the consent of the deceased, but you have to get the consent of a relative or so. And, you know, I think there's some questions around that. And again, these get to the dignity issues, the very idea or statement. And again, I'm just responding to what was said last week, which is that the deceased are not human is troubling from my standpoint as a scholar of working in the humanities. I mean, that's troubling. Right. And at the same time, my feeling troubled about that, and I think others do as well, because I've heard from quite a few people on this, still recognizes the fact that we're in a pretty desperate situation and we need some research, right? You know, this is an existential threat that could kill us all if it's not gotten under control. So I certainly recognize that, but that's then the question, that's where we get to where I think there has to be some communication and conversation and coming up with a solution and what do we do in this situation?
Yep, let's talk.
So I'm not offering and saying one way or the highway. I'm saying it's something we need to discuss.
Thank you. And Andy, if we can keep both the question and the answer short because we're running out of time.
Margaret, I want to thank you for your presentation. And as a historian, I want to, based on what we've learned from other situations like in Tuskegee, where it led to changes in laws to protect patients, do you see a potential solution that could be applied immediately? And then obviously long-term solutions will be much more difficult.
I think we do need to think about immediate steps, and then I think we need to think about long-term solutions. But for certainly in the long term, I think one of the things that has to come out of this is that we have to get on board with health security as a human right. And we cannot allow it to continue where you have populations that simply don't have access to the health care that they need. So they wind up in the position that they are vulnerable to begin with. So, you know, whatever that takes in terms of political changes, electoral changes, or legislative changes, whether that takes place beginning at a state level and then ratchets up to a federal level, whatever is necessary, I think that we have to do that. But I also think that in the immediate term, we need more outreach. I think that, and the other thing I would say here is that there is, and please don't take this the wrong way, but the media in some respects has put a very white face on a disease that's marked by Black and brown death. And that's a problem. And I think that what you need to do is bring into the fore certainly those populations or people of color who are working in the sciences and also working in medicine, so that there is visibility of diversity at that level. And again, you know, if you want to think about something immediately within the context of Columbia, well, it's a season where people are applying, right? And this is certainly an opportunity to increase the diversity of graduate students in the sciences. And that certainly would be an immediate something that we could start.
Okay. Thank you. Brent Stockwell.
Hi, Margaret. This was great and really informative. I guess I just had a similar question about, are there historical precedents where discriminatory or even genocidal policies were in place but then reversed, and what was the framework for reversing that?
That isn't a question in terms of reverse that I don't think that there's a precedent for, or certainly one that is well researched. Typically, the research on genocide looks at obviously genocide. And the event has occurred. What has the shift that has taken place in terms of the historiography is that the focus has been on the punishment of genocide. And the interest is, how do we get to the prevention of genocide? So where we are now, for example, all right, in the case of COVID-19, you know, can we look at dynamics in this and say, okay, look, these might point towards the possibility of slipping into genocide, and put a stop to it. So in other words, the focus has been on not so much looking at the crime of genocide post-fact, but can we stop it? And that's the focus. Okay. And I do think we have an opportunity here. And again, you know, I want to be careful. I'm not saying this is happening, and I'm not sort of launching any accusations, but I'm saying there are dynamics at play because of long-term disparate impact and slow-moving genocides where we could be in trouble here.